Assalamu alaikum. We'll start the clinical consultation day with this scenario. Miss Lisa, 25 years, referred with complaint of amenorrhea. We start after sharing the timer. Okay, ready? Dr. Abdullah?
Just give me a second.
Okay.
Okay, so yeah, let's start. Hello,
Okay. Hello.
my name is Dr. Abdullah Al-Malla. I am one of the medical doctors here. Am I speaking with Miss Lisa and you are 25 years old?
Yes, I am.
I hope you are comfortable today, Miss Lisa.
Yeah, I'm fine, doctor.
I am here to take history and examine you and address your concerns. And I will be writing notes. I hope you are not bothered with that. Would you tell me what brought you here?
Yes, doctor. I went to my GP for the last 6 months. I don't have period, doctor.
Okay, I'm sorry for that. And did you have anything more you know want to tell me? Any symptoms exactly you want to mention apart from that?
Actually, doctor, I went to my GP many times. I asked
Mm,
him, and he
mm,
referred me to you. Uh, Apart from this, doctor, I don't feel anything abnormal. Only,
mm.
the girl issue. I'm worried, doctor.
Can you, okay. Can you tell me, I want to, do you feel this amenorrhea uh, uh, is coming before there was some fluctuation in your period before it?
Actually, doctor, I had my period before. Uh,
Was it regular all the time?
yes, it
Okay.
was started at the age of 14, and it was okay.
Mhm.
Then I
Okay.
noticed it become more less and
Mm,
more
mm,
a long
mm,
time.
mm,
And
mm,
finally, this last 6 months, I don't have at all.
mm. And was there any possibility of um, pregnancy?
Doctor, yes, I hope I can get pregnant, doctor. I
Okay,
have partner, but
okay, okay.
I'm stuck now, doctor. I don't know what happened. I'm not
Ha-
pregnant,
have
doctor. I'm
have you
sure.
thought? Okay, have there been any? Do you have any children?
No, doctor.
And was there any problem with the fertility?
No,
I'm sorry for
doctor.
that.
No, we just had a marriage
Okay,
recently, one
that's
year
good.
back,
That's all.
and yes.
And well, I will ask you more questions. You may feel it may not be linked, but please answer me
Mm-hmm.
yes or no. So, did you have any headache?
No, doctor. I don't have
Did
headache.
you, yeah, did you have any problem with any abnormal sensation in hands or feet?
No, doctor.
Okay, did you have any weakness anywhere?
No.
did you have any problem with your appetite?
Um, no, doctor, but yes, I'm noticing my weight is increasing.
Okay. So how much is it increasing and for how long?
Yeah, doctor, it's 3 kilograms for the last 6 months.
Okay. And did you notice any skin changes like acne, any skin rash,
Yeah,
discoloration,
yeah,
pigmentation?
doctor. I am bothered with this thing also, doctor. I notice a lot of rash and acne in my face and my
Mm,
back.
mm,
Yes, you're
mm,
right.
mm, mm. And did you have any pains in your tummy
Sometimes,
or
yes,
the
doctor.
pelvis,
I feel in the lower part of my tummy, I
the
feel,
lower tummy? Yeah.
yes, exactly, doctor.
Okay. Okay. Is it on the right or the left?
No specific, doctor. It's dull aching. Sometimes I feel to the right, sometimes to the left.
Okay. And was there any problem of, I'm sorry for that, any problems of secretions down there?
No, doctor.
Okay. Do you get any problem in your sense of smell?
No, no, at all, doctor.
And do you get any problems in your vision?
No, doctor.
Any swallowing issue?
No.
Okay, I want to ask you, do you get any problems in your mood? Do you notice your mood is kind of out of
No, no,
usual?
no. Uh,
Okay,
I'm fine, doctor. Just I'm
and
worried about these things.
yeah, okay, sure. And did you have any problems? Okay, how is usually um, your how's your was there any problem in like excessive loss of fluids, vomiting,
No,
throwing
no,
up?
no. No, I'm
Okay,
fine.
okay, okay. And before, were you admitted with any non-medical condition?
No, doctor.
Okay, and did you have any uh, in the family any any condition, similar condition?
My mother was having cancer in her ovaries. That's it.
Okay, okay, and okay. So and how is do you take any medications regularly
No, doctor, I am not.
and over the counter?
No, I'm not.
Okay. And I'm sorry for that. Do you have any illicit medications you are
No,
aware of? Okay.
never,
And
doctor.
okay. And what do you do? What do you do or work, Miss Lisa?
I'm accountant, doctor.
Okay. And is that affecting like very stressful on you?
No, it's not, doctor. Just my look with the acne. I'm trying to cover these stuff.
Okay.
But the most concerning now, I want to have baby, doctor.
Okay. Okay. Um, okay. Uh, so I want to ask you, do you get where do you get the acne more?
In the
Is
face,
in
doctor.
all in the face, and is there any other rash you mentioned also?
No, no, doctor. No rash.
Okay. And is the acne making s- uh, 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 making a material coming from it,
Yeah,
out of
yeah,
it?
yes. Some, yes, you mean black dot and like that? Yes, I have. Yes,
Mm-hmm.
all kind of acne I
Okay.
have.
Blood.
No, no,
Okay. And are they quite itchy?
no,
Not itchy. Okay. And okay. Any problem in the eyes? Is there any redness in the
no,
eyes
no,
or
at
the
all.
mouth?
No,
Okay. And do you get any ear pain or ear infections?
No, doctor.
Okay. Let me ask you, do you have any problems in your heart, the feeling of your heartbeats
No,
bounding? Okay. Do you get any do you get any feelings of sometimes you're getting more short of breath or
no.
tightness in your chest? Okay. And do you get any tummy distension?
Yeah, I feel yes, little distended and
Okay.
yeah, and
Okay.
as I told you, I am little obese, doctor.
Okay. Is
Uh,
it more in the tummy or all over the body?
yeah, more in the waist.
More in the waist. Okay. And is how is okay. And was there any the acne came after the weight or before it?
I was before, doctor, but I notice more now.
Okay. Okay. And what have you used anything to ease it all this time? Any creams? Any?
No.
Okay, that's fine. Um, okay, I want to ask you again, have you, I'm sorry for that, but have you had any casual relationships?
No, doctor. I have my partner.
Okay. And any blood transfusions?
No.
Okay. So I want to examine you,
Yes,
and
sure,
if I
doctor.
have a question, I will ask you. Is
Yeah,
that all
what you
right?
want? Okay, doctor, sure. What you
So
want to ask
I want
about?
to see the vitals chart and I
Yeah,
will see the BMI.
excellent. Yes, BMI 35 and the blood pressure 140 over 90, blood sugar
Okay.
borderline 7 millimole, and
Miss
what
Lisa,
else?
do you get high abnormal thirst feeling usually?
Not so, doctor. I am not feeling this.
And is the urine more frequent?
Yeah, doctor, I noticed, yes, more frequent nowadays.
Okay. And okay. And I will check okay, I will check I will see the acne itself.
Yeah, there is
Before the
acne.
acne, is she pale?
Sorry, is there it?
Is she pale before the acne?
No, no, she's not pale.
Okay. And okay. The acne, is there any picture? No?
No, all
Okay.
features or
Okay. I will,
manifestation of acne
okay.
you can see in the face.
Okay. Okay. Okay.
And
And,
also there is some hair shortage
mm, okay.
in the beard.
And I want to ask you, I'm sorry for that. Is there any milky, this abnormal
No, doctor,
uh,
I didn't notice that.
okay.
You mean from the breast? No,
Breast, yeah. Okay. So I need to check on, do you get any cough?
no, doctor.
Okay, that's all right. Um, I will check the lymph nodes and
No, no lymph nodes.
okay. And I need to see inside the mouth.
Nothing in the mouth. No, no
Okay.
pigmentation. Nothing
Yeah.
specific.
Okay. Where is the hirsutism more in the body?
In the beard,
Where?
in the face, down area of the
Okay,
face.
okay, okay, okay. It's not all over the chest
No,
and the abdomen?
no.
Okay. Okay. And I will examine the abdomen for I will look in the area of the tenderness. I will ask her where is the tenderness?
Yeah, mainly in the lower part, but diffuse
Mm,
enlargement because of fat. You cannot feel anything.
mhm,
2 minutes remain.
mhm. Okay. I will check the lower limb for any swelling or rash.
No rash, no swelling.
Hmm. And is the back okay?
Yeah,
Okay, that's all right.
Apart from acanthosis nigricans in the shoulder area.
Okay, that's all right. And okay, Miss Lisa, what is your concern?
Why, doctor? I have this problem. Any chance to get pregnant, doctor?
No, I'm sorry, Miss Lisa. It's actually, it looks like you have something making your the problem in the periods and the weight gain. More, we have multiple things we are suspecting, but first suspicion is that there is we need to run more scan for your ovaries, and I'm suspecting that there are maybe cysts there. Um,
What you mean by cyst, doctor?
like cystic swellings inside the ovary. We need to have a look to them
You mean
and
sacs, doctor,
sac,
right?
yeah,
Yeah.
sacs.
Okay.
Okay,
Okay, doctor. What about the acne? Any chance to disappear
we
in
need
the
we need to, yeah, we may give you something for that, medications, and we will see the response the days later. It may not go away. Yeah.
Okay, doctor. Thank you. Time's up.
Mhm.
What's your case about? Present
Okay.
your case. Mhm.
Yeah, this is 25 years old Mrs. Lisa. She has presented with amenorrhea for 6 months, secondary amenorrhea, with features of weight gain, and hirsutism, with uh, also acne. These
Mhm.
features indicate more likely to me high increased androgen secretion, and with she has a high body mass index. She's obese with a high blood pressure, and these features indicate coexisting metabolic syndrome features. Uh, Along, she has an examination, acanthosis nigricans, and she had um, also a problem in the tenderness in the pelvic sites of indicating possible ovarian uh, problem. So my differential diagnosis is that this amenorrhea from ovary problem in maybe polycystic ovary uh, syndrome, or second, it could be other pathology of endocrine, such as Cushing syndrome, um, or uh, adrenal adrenal um, yeah, Cushing syndrome from
Hyperplasia.
secondary, yeah,
Hyperplasia, you mean?
yeah, adrenal hyperplasia.
Okay.
uh,
What other
mhm.
common or not common? I mean, you something you
A
screamed about,
common
and
problem is anorexia nervosa,
yes, good.
hypothalamic
Yes.
dysfunction due to anorexia or bulimia nervosa.
Hmm. And you rule it out, right? By
Yeah,
the throwing
she
up,
has good appetite.
yeah, and the
She doesn't
appetite.
have
Okay.
problems in the yes.
What else you could think about?
I could think of especially concerning the hirsutism, which with amenorrhea, I should exclude cancers of the adrenal gland,
Ovarian cancer,
or
especially with family history. Yes.
or genital, yes, ovarian cancer. Yeah.
Okay. How to investigate this patient?
So, baseline investigations, biochemical tests, and will need to check the we need to rule out diabetes.
Okay.
We need
Fair.
to look for hemoglobin A1C with the
Excellent. Yeah.
blood with monitor random blood sugars and urine tests, and also we need to look for the endocrine panel, um, uh,
Excellent.
or looking for FSH, LH, and
Okay. And what do you
ACE.
expect? LH to
Yeah,
FSH,
yeah,
which will
yeah.
be rank?
In this case, if it is I may suspect FSH increased over LH ratio.
No,
In
LH.
the if it is
No, the LH. LH more than FSH.
mm,
Okay.
LH more than
Yeah,
FSH. Okay,
LH
if it is
ratio to the FSH raise. Okay, what else?
LH. Uh, um, what else is
Two more
if there
hormone.
is yeah, if there is features that if there's these might guide me to a pituitary test if needed, if they are not suppressed.
Okay, you are
And I will,
screening for the cause. Yes.
yeah, I will need to look to um, I need to check with the scans. I've done ultrasound
Okay,
and pelvic, mainly
before the
pelvic
scan, let's
ultrasound.
finish
Yeah,
the hormonal assay. What
yeah, hormonal
hormone you
assay.
suspect to be high or normal?
Okay, I need to check the testosterone levels
Excellent. Yeah,
and
high or
uh,
normal? Yes. Okay.
yeah, dehydroepiandrosterone also. Dehydroepiandrosterone, which is the active form.
Okay. What specific or not specific? What other tests you can do will be low, like six binding?
Yeah,
Yes.
which is the estrogens and progesterone levels.
No, no. I'm asking. Saying about six hormone binding globulin. It will be low.
Yeah, six binding globulin. Yeah,
Yeah, it
six
will be
binding
low because
hormone globulin.
occupied
Okay,
more. Okay, by testosterone.
okay, okay.
Now, how to manage this patient?
Okay. Well, first she will need admission for investigations and management of her metabolic features of high blood pressure and
Will you
possible high blood
admit?
sugar.
Will you admit this patient?
Y- Yes, because there's concern of cancer possibilities, so we need to rule out that.
So
And
it can be done as outpatient, right? Referral and outpatient.
mm,
It's
mm,
no
mm, mm.
emergency now
Yeah,
for admission, right? Okay, go ahead then.
yeah, can be done as outpatient. Okay, I need to educate her about possibilities and what about her condition.
Mhm.
We need to
Okay, she will ask you three
run a
questions.
multiple disciplinary team. Yeah.
Yeah, she will ask you three questions. Doctor, I want to get pregnant. This is my most important concern. What you give her?
Yes. Yes. If she wants pregnancy, then we can uh, uh, for fertility. There are some medications. If it is polycystic ovary, it can help. Uh, yeah.
Okay, so
I'm not sure of the name.
clomiphene and metformin, right?
Clomiphene.
Clomiphene,
Yeah.
yeah, clomiphene and
We need to
metformin.
counsel her also before starting the medications of the risk of DVT, deep vein thrombosis.
Okay, and the most
Yeah.
important in all line of management for polycystic ovarian
Uh,
syndrome, which is
yeah. Treating the acne
no, no, before
we
the
can
acne, the cornerstone of management is weight
yeah we
reduction.
can start med for weight reduction. Yeah.
Yeah, weight reduction
If
before everything.
failed, we
Yes.
can give metformin. Okay.
Okay, and if she doesn't care about conception, what you can give her? I mean, for the her concern is about the period. What you can
Mm,
give
mm,
her?
mm, 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 mm. Uh, if it is the I'm not
Con-
sure. If it
Contraception,
is
yeah,
the
oral
period,
contraception.
contraceptives. Okay,
Yeah,
oral
combined
contraceptives.
one. Okay.
Okay.
And if she concerned about the acne,
We can give topical contraceptives.
I don't know. Is it contraceptive? You mean the
Uh, topical combined um, estrogen and progesterone,
No, I
is
don't
it?
think it's hormone, right?
Okay.
You mean the I think I forget the name. It's a difficult name. Efflorinethine.
Eflornithine,
Efflorinethine,
eflornithine
yes. Efflorinethine, yes. Efflorinethine. This for the acne,
for acne.
and
Okay.
yeah, sometimes also they are giving uh, contraception co-cyberinidol. Of course, we cannot remember all these names. At least remember the contraception and the conception. Yes, oral contraception. Yes, it's
Oral
third generation
contraception.
contraception. Yes, yes, it's
Mm.
oral or third generation contraception. This is for the acne.
Third
So
generation.
the three concern in this patient: conception, clomiphene, and metformin. If no need or she's not caring about conception, the third generation contraception or contraceptive pills. If she's concerned about the we finished the acne and the conception and the period. If she is concerned about the amenorrhea, we can give her contraception. Sorry?
أكني بنديها إيه؟
Acne, third generation contraception.
For acne?
Yes. Acne and
Eflornithine.
hirsutis. Yeah. There is medication. Difficult to memorize this name. Allah, I can't even after you finish, you will forget it. Let me revise it again. It's called
طب معلش يا دكتور أنا كنت بس عايزة
L4-inithine. 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 L4 or sorry, efflorinethine. Efflorinethine. This is a specific medication for the acne. Anyway, you can refer to the dermatology if you don't remember the name, or you can say third generation contraception or oral contraceptive pills, and for the ovulation, metformin and clomiphene. That's it. Okay, I know it's a little difficult to memorize all this medication, but at least I mentioned the multidisciplinary team and oral contraceptive pills in case of amenorrhea, if she's concerned about the amenorrhea. And for conception, you can mention the metformin and clomiphene. For the acne, you can say yes, third generation contraception or oral contraceptive pills.
أنا عايز أسأل سؤال بس معلش
Yes.
الديفرنشال اللي احنا حطيناه إيه؟
Yes,
أول حاجة في الأمرين
I will say all the topic now, Dr. Shah. I will comment from the beginning for Dr. Abdullah, then I will mention the differential, okay? Okay, let's start from comment. I think Dr. Abdullah didn't practice this scenario before because even if you put differential, you can go through the differential. You didn't put a differential. That's why you went haphazard between the system review, I mean. But if you put differential, you give me good differential, which are polycystic ovarian syndrome,
Polycystic ovarian
Cushing,
syndrome.
Cushing. And you can ask me a question for Cushing, right? You can ask me a question for Cushing. Even you can specify a question, are you taking steroid medication called steroid? The other and very important differential in this patient, the thyroid. Any disturbance in the thyroid can lead to amenorrhea, either hypo or hyper, and more common with hyperthyroidism, okay, thyrotoxicosis. It's common for amenorrhea. Prolactinoma you screened for by asking about the headache and vision problem, right? So this is for secondary amenorrhea, when the patient has a period before and now she doesn't have. So this is what's called secondary amenorrhea. The first differential polycystic ovarian syndrome. The first is polycystic ovarian syndrome. The second, prolactinoma, hyperthyroidism, pregnancy, of course, very important to ask about, and you ask it. This is normal physiology, but the patient will come to you in the first or second month. It will not wait for 6 months, and she will have, of course, baby, and she will know she is pregnant. Anyway, the other or the fifth one, anorexia nervosa. If the patient underweight or cachectic one, or had mood problem or depression or whatever. This is the differential, Dr. Shema, for the differential. Okay, you ask about differential. So if you want to repeat again, secondary amenorrhea. First, polycystic ovarian syndrome, prolactinoma, hyperthyroidism, and Cushing syndrome. You can add to them pregnancy. You can add also panhypopituitarism, maybe also Sheehan syndrome. So you have a lot of differential, but the most common
وليه كوشن جامد أمينوريا؟
steroid also, and some patient will have high testosterone level after conversion of estradiol to testosterone, and they will have the same features, acne and hirsutism. Okay. Primary amenorrhea, which means patient doesn't have period since puberty, and this is mostly chromosomal, like Turner syndrome and Kallman syndrome, or failure in the pituitary itself.
Yeah.
Okay, there is what's called premature also ovarian failure, but it will come later with other autoimmune association, but it will be elderly a little bit. It's called early menopause syndrome, but you can still put it as differential. Okay, so whatever you are starting
الثانية
such
بس حضرتك قلت برايمري
premature
primary
ovarian
amenorrhea.
failure, premature ovarian failure.
بس دي مش secondary.
Secondary. Yes, I said this is a secondary. Primary chromosomal issue like Turner and Kallman syndrome. Okay, this is this patient or this type of patient, they will not have period at all. And by the examination, by the way, Dr. Abdullah, you can offer, can I examine for the hairs distribution and of course the breast and the discharge. You want to rule out the causes, right? So you can do examination for the prolactinoma, for example, for the hand size, for the vision, and also you miss the occupational. Only you ask for the job. You didn't ask about alcohol and smoking. So please, if you are not prepared for a topic, try to put any cause or any reason you know as differential and ask about the differential. For this case, if you put 3 or 4, like pregnancy, you will ask about pregnancy. You will ask about thyroid, which you miss. And you can do also examination of thyroid. You will put also the Cushing, and you will ask, they will examine Cushing, bruises and thinning of the skin, hairs distribution the same, and fat in the interscapular area, bone phase, this for Cushing, okay? Polycystic ovarian, our case here, hirsutism, acne, and you can offer ultrasound for the pelvic ultrasound. Or for more specific investigation, you can do transvaginal ultrasound. Okay, again, the investigation for the case, apart from baseline basic investigation, specific investigation will be in the form of hormonal assay. LH to FSH ratio, LH will be high, testosterone will be normal or high, sex hormone binding globulin will be low. These are the investigation for polycystic ovarian syndrome.
دكتور LH تبقى أكتر من FSH صح؟
Yes, LH more.
وإيه تاني غير الهرمون التستوستيرون؟ LH والFSH والتستوستيرون؟
And sex hormone binding globulin. SHB, BG, SHBG. Sex hormone binding globulin will be low because of will be occupied by testosterone. Okay. Investigation, ultrasound abdomen. And also if you can put another differential, ovarian cancer, if there is family history of ovarian tumor or ovarian cancer. Okay, this is the case, Dr. Abdullah. Well done, you reached your diagnosis, but please put differential whenever you don't remember the system review, or you don't know how to go through the system review, because yes, it's I know it's embarrassing, especially if you are talking to a female patient, but at least ask for the topic you might know as a cause for that, like what I mentioned. And for the onset course duration, you can ask when it started and did you have it before, How was it before regular? How was the amount? And the thyroid here is very important, crucial important. You missed it at all. Even if you went through the system review, you can catch the thyroid if the thyroid is the cause. You should ask about that intolerance to certain weather. Okay?
دكتور premature ovarian failure أو syndrome premature ovarian failure ده بتسأل عليه
Premature
ازاي؟
ovarian failure.
بتسأل عليه ازاي؟ بتسأل عليه بأذر autoimmune
Yes, it will come. Yes, autoimmune association. Like Addison, like vitiligo, or BBC, primary biliary cholangitis. Okay. Any question for this scenario?
Assalamu alaikum, Dr. Basim.
Wassalam wa rahmatullahi wa barakatuh.
Thank you for this case, and also Dr. Abdullah, I think he did well. But
Yeah.
also we need here as differential, don't forget hypothalamic amenorrhea. Especially this patient has weight gain, might practice excessive exercise or on stress because of this weight.
Yes. This is one. Yes, you're right.
Also, regarding premature ovarian failure, especially associated with autoimmune hepatitis, as a presentation of autoimmune hepatitis. Also, we need to ask about jaundice and other
Yes.
autoimmune. Also, in panhypopituitarism, we need to ask about thyroid and
Yes.
Addison, because hypothyroidism, secondary hypothyroidism associated with amenorrhea, primary hypothyroidism associated with menorrhea.
Yes.
Yes.
Yes,
But
you're right.
other one. Also here we can put this polycystic ovarian syndrome might overlap with metabolic
Metabolics.
syndrome.
Yeah, he mentioned it. Yes, he mentioned it. Yes. Especially if you
So
have
we
the.
need to add also lipid profile in investigation and fasting blood sugar and hemoglobin A1C, and also anthropometric measurement including
Uric
waist
acid.
circumference and BMI
Yes.
in this patient also.
Yes.
You are right.
And uric acid as well. Yeah.
Yes, you are right. Yes, thank you.
Thank you, Dr. Mahmoud. Thank you so much. Yeah, I think. Yes.
I have a question.
Yeah,
So
sure.
regarding the concern, if it is amenorrhea, you said we give her contraceptive pills. I missed this part. I did not get it.
Yeah, there is three indication or three categories of patients. One patient will ask you, please, I want to have pregnancy. So you have to control the hormones and the weight by giving first reduction of the weight and giving metformin along with clomiphene. Okay. This is for pregnancy. If the aim is pregnancy. Okay. If she's aiming for no need for pregnancy, just to control to have a regular period. This patient, you can start her on oral contraceptive pills. And if she's concerning about the acne and the hirsutism, you can start the patient on eflornithine cream or third generation oral contraceptive pills. It's
So
called
the oral contraceptive pills help with the amenorrhea? They are for the management of amenorrhea?
Yes, it will because it will be combined hormones. It will be induction for the ovulation.
Okay, secretion. Okay.
Yeah, induction of the ovulation by the regular hormone
Can
ingestion.
we say to refer to a gynecologist?
Best way in such case to mention multidisciplinary team. If he asks you what the pharmacological, what the concern, if you will give her if you will answer her concern, how to answer the concern, unless to refer her, either to refer her or to try to specify the concern specifically for each one, how to address. But if you don't know for any disease and any condition in PACES, if you don't know, please refer to the concerned team or specialized. Yeah.
Okay, thank you.
Of course, this topic
Dr.
you might.
Basim?
Yes, sure.
in the case of amenorrhea and obese and كده there is differential obese pregnancy صح؟
Yes, we can
يكون
put pregnancy,
فيها
but
additional choice.
against that, you can say
Mm.
patient has other finding, a pathological finding, for example. I know there is also acne associated with pregnancy, but she will have the test for
Estrogen,
pregnancy.
obesity, everything.
Yeah, can
Also,
be, yes.
also this we can exclude this in history. Ask patient, are you pregnant? If no,
Yeah.
when last time you did the pregnancy
Yes.
test? If
Yes,
before,
exactly.
yes,
She might be pregnant and if she came to you the second or third month, it's difficult to answer this question because she might be still pregnant and she didn't do the test. You will do
yes,
everything.
but
You will find
my
everything normal apart from the period. So it might be pregnant.
yes,
Yeah.
yes, yes. If
We
she
can just
did this
mention in the
test before 1
investigations
week,
to do the
exclude
pregnancy
this.
test.
Again.
Like part of the
also,
management plan, we can just say we will do a pregnancy test to exclude pregnancy and then just move on with the rest of
Yes.
the
Yes.
management.
Agree. Yes.
Also, one of differential, sorry, non-classical congenital adrenal hyperplasia. Am I right?
Again, what's called?
Other differential,
Yes.
non-classical congenital adrenal hyperplasia.
cause
I
secondary
think
amenorrhea or primary
Patient will be
amenorrhea.
obese,
okay.
has
This is for written
symptoms.
part. Yeah, this is for written part. But I mean, in the paces, they need the common, not something
Not
written.
common.
Yeah, in the box. Yes, you're right.
Okay.
But if you can remember it, you will mention before hypothyroidism, for example, or hyperthyroidism. You will mention it before acromegaly. No, there is common and less common. The less common, they
Right.
don't need. Even in the differential, they have mark for the differential. If you put weird syndromes, they will cut the bark. What they need from you to give them the common, then the less common, then the less. So the first three should be very common. If you want to reach to 10, you can put your differential. But if you put as common, you have to put pregnancy, as we said. You have to put also
Yes, yes.
thyroid. Yes.
And also in this case,
You're
I think
right.
mentioning anorexia or bulimia nervosa
Yes,
could,
but against that,
yes, I think
patient-
it's not good to mention them because with the obesity, I think they could decrease us in the differential diagnosis.
yes, it's
having
against.
put them.
Yes,
Yes.
it's again because she's not obese. The anorexia will be underweight. That's why I mention it only for scientific points. But if you want to mention again the differential in the exam wise, you can start with pregnancy, then you can put polycystic ovarian syndrome because the classic for presentation. Pregnancy you can put second, and thyroid abnormality, either hyper or hypo, and you can say hyper more common with amenorrhea, hyperthyroidism. Then you can put acromegaly because also no signs of acromegaly here. Prolactinoma. And the other cause like Cushing, also there is no signs of Cushing. So the most related here, the Cushing, the polycystic ovarian pregnancy, and also Cushing here also related because the hirsutism and the acne. Okay, let's repeat it again in order. Polycystic ovarian, then pregnancy, then Cushing, then thyroid. Okay.
Okay, tamam.
Okay, thank you all of you. Very nice discussion today. I like this way for discussion and interaction.
باسم السلام عليكم.
السلام ورحمة الله وبركاته.
Last year I think
Uh-huh.
the كان الكونسيرن مشترك في كل السنترز انه
Mhm.
can I get pregnant again?
Yes.
Can we just elaborate more for what can be treatable and manageable? For example, premature ovarian failure, for example, she has no chance to get pregnant again.
Yes.
But in case of thyroid, I think polycystic, other just we can elaborate more with in which condition can get pregnant, and in case of the main concern was, can I get pregnant soon or
Yeah,
no?
what do you think in polycystic ovarian? She can, right? She
Yes,
can
Yes.
still.
she can.
Still, she has the
She
access.
can after
Whenever,
management.
Yeah.
whenever she has the access of hormone, she can get pregnant. The problem
Yeah.
if the axis is disturbed, like as you said, premature ovarian failure. Already the axis or the hormone itself from the pituitary gone. What
Mm.
else? Like chromosomal ones, impossible, of
Yeah.
course. Coleman and
Thyroid.
thyroid, if treated, it can be because it's
Mm.
related to the thyroid. It's not primary ovarian or it's something outside the ovary. The problem when you have ovarian failure, this is the most difficult point. Okay.
Yes. Mm.
Other disease can be, for example, you remember cystic fibrosis and Cartagnar ciliary immotile syndrome.
Yes. Yes.
Which one can get pregnant and the other?
Females
I
can
mean,
get pregnant otherwise, but in male, because the problem in the birth difference show no chance to get
yes,
pregnant.
yeah. So both of them can be. I mean, in the female, but the problem in male. So
Yes.
both, yes, subfertility, not fertility, infertility, subfertility.
Yes.
Also, myotonia dystrophica, subfertility. So I think this is the most common amenorrhea and fertility question in basis. And as long as the axis is intact and the hormones still preserved, so she can get pregnant. And if you have doubt or you are not sure, refer her to a woman doctor or a fertility doctor. They can do that, and they can address her concern. If you don't have clear answer or 100% sure answer, okay. Thank you, Dr. Abdulman, for this question. Nice question related to the practice and basis. Any other comment or question? Eflornithine cream. Yes. Let's go to the second scenario. Dr. Abdullah, can you write the scenario, please? Mr. Ahmed, 80 years, colorectal cancer. He felt dizziness and his blood pressure was low on the next day of his chemotherapy. On the letter you read also he has blank episode noticed and past history of lobectomy for liver metastatic lesion. You are the medical registrar covering full medical assessment, address his all concern. Okay. Give me 2 minutes, then we'll start.
Is this communication case
No, it's
or long case?
long. But Dr. Abdullah has revenge for me.
No, Allah, it's very easy.
80 years? Okay, no problem. Okay, let's start.
Yes, let's start.
Hello, I'm Dr. Mukhtar, the doctor in the ward today. You must be Mr. Ahmed.
Yes, I am.
You are 80 years.
Yes, I am.
We are here to discuss about your health issue. That's okay for you?
Yes, okay, doctor.
How do you feel now, Mr. Ahmed?
I can't stand up. That's how do I feel. It's really bad.
Yeah, I'm so sorry to hear about that. Do you still dizzy?
No, when I sit down, it's quite quick, improving.
Okay, when you stand only.
Yeah, when I stand, it's only, yeah.
Okay, when that started, Mr. Ahmed?
Well, this is the first time ever happens with me. Yeah, it didn't happen with me before.
Okay, and you feel it's worse day after day?
Yeah, it's just I came to you today. This is since the morning. I had a chemotherapy yesterday, and I have this. I feel it is worsening. Yes.
Okay, and when exactly started the first time?
Just today. Yeah, this is one day after the chemotherapy. Just today, and since the morning, I feel it's more worsening.
Okay, Mr. Ahmed, you are saying that it starts whenever you stand from sitting.
Yeah.
Any other particular time or any particular movement you notice it can lead to these attacks?
Sometimes when I eat.
Okay, when you eat.
Mm.
Okay, do you feel your heart beats along with that?
No.
Okay, and you feel any tummy pain?
No.
Any shakiness of the hands?
No.
Okay. Whenever you feel this dizzy, what thing you can improve it or you notice it improve it?
Just sitting down
Sitting.
and resting myself on the. If I lie down, it would be better.
Okay. Did you ever lose your awareness for the surrounding?
Yes, yes. My team, I've been told that I have these episodes that I lose my. So, doctor, I have two times I have lost two. It's they look different. I lose like They say I'm just like looking, and I'm not responding. The other time is that I really, that's related. I think when I stand up, I feel dizzy. I had that feeling of really bad dizzy one time today, to the degree that I almost lost my consciousness.
Okay. And along with that, did you measure your blood sugar or anyone measure your blood sugar?
Yeah, it was fine. Blood sugar was fine. They measured
Okay.
for me in the
Anyone?
office in the GP.
Yeah. Did you bite your tongue?
No, I didn't.
Did you wet? Sorry for this question. Did you wet yourself?
No.
Okay. Mr. Ahmed, may I know what are you diagnosed with any condition before?
Yes, I have the cancer in my colon
For how long now?
and receiving. It's almost discovered 1 year ago,
Okay.
and they said it's quite. It was discovered when it spread to the liver, and they removed that part and started me chemotherapy.
When the surgery happened?
It was 1 year ago.
Okay. And can I know the chemotherapy medication? You know the name, or you can show me your medication list?
Oh, okay. I'm not taking the chemo now at the moment.
Mm-hmm.
I've been the. Okay, I will show you the medication list. I take atorvastatin. I take lisinopril, I take amlodipine.
Okay. The chemotherapy
Yeah.
name you can remember?
Yeah, they said it's a multiple medications. You can say okay, I will tell you one by one.
Okay, till you remember the
The
names.
combination, yeah. Folinic acid, fluorouracil, oxaliplatin.
Okay. And this is the first time to take the chemotherapy, or you are taking regularly?
This is the first time. Well, I took almost 12 sessions, and after this, I started to feel like that.
Okay.
Before this is the yeah.
Are you allergic to any medication? Are you non-allergic to any medication?
No allergy, no.
Okay. What you have a catheter in your any blood channel in your body?
Yeah, I have in my right arm. You are right, yeah.
When it was inserted?
Yeah, it was inserted with that beginning of the chemotherapy. They said it's connecting me for the chemotherapy sessions.
So
So
for
it
1
was,
year now.
yeah.
Okay. Any other surgery apart from the liver surgery?
No.
Okay. Any other procedure?
No.
Okay. You have any high body temperature?
No, I don't.
Any lumps or bumps?
No, I don't.
Any night sweats?
No.
How is your weight and appetite?
My weight is just stable, you can say. Yeah.
And appetite also?
Yeah, appetite is okay.
Okay. You have any headache?
No.
Any blurring vision?
No.
Any unsteadiness?
No.
Any weakness?
No.
Pins and needles?
No.
Okay. You have any short of breath?
No.
Any chest pain?
No.
Any difficult swallowing?
No.
Okay. Any tummy pain?
No.
Any weather preferences?
No.
Any change of your water work?
No.
Okay. Any family history I should be aware of in your family? I mean, cancer or gland problem?
No.
Okay. Mr. Ahmed, any travel recently?
No. No.
Okay. You are taking amlodipine, lisinopril, and atorvastatin. Are you diagnosed with high blood pressure?
Yeah, high blood pressure. I'm sorry, I didn't mention that. Yeah.
Okay. And any high blood sugar?
No.
Are you compliant to this medication?
Yes, I am.
Do you have any frequent water work nowadays?
No.
Lose motion?
No.
Anyone told you
No.
like
No.
you are paler than before?
No. I'm fine.
Any the yearly discoloration of your eye?
No.
Okay. Do you smoke?
I was smoking. I stopped smoking with this chemotherapy.
Okay. Do you drink
Yeah.
alcohol?
No.
What's your job?
I am cleric in I retired from cleric, being cleric in the
Uh-huh.
yeah.
Okay. Any lose motion recently, Mr. Ahmed?
Uh, no, no lose motion.
Any
Emotions are stable.
okay, any blood coming from back passage? Sorry for this question.
No, there are no.
Any throwing of blood?
No, there are none.
Okay.
It's blood.
This medication, did you increase the dose recently? Amlodipine or lisinopril?
No,
When it was
the
started?
it was so I have this. It was started, can say 2 years, and the blood pressure, it was quite stable and even high just before this month,
Okay.
the last readings here.
Did you take, or are you taking any water pills medication?
No,
Okay. Are you taking good water?
good water. Yeah, I am.
Yeah. Okay.
No, not
May,
much. I sometimes forget.
okay. May I
I think, yeah.
examine? Yeah. May I examine the
Yeah.
patient now?
Yes,
Starting by the
sure.
general look. Is he ill? Looks ill?
No, he looks well. No, he's well looking.
Okay. The vital chart, blood pressure sitting, standing.
Yeah, so his sitting blood pressure is 100 borderline, like over 70. When he stands up, it becomes 60 over 40.
Okay. And the pulse rate,
Pulse rate is stable when he stands up, and sitting the same, 80 per minute. And
okay,
respiratory
regular.
rate and saturation normal. Yeah, regular.
Okay.
Yeah.
Any collapsed pulse? The volume of the pulse?
No, volume is normal. There is
Normal
no
volumeless.
collapsing bone.
Okay, you told me you don't have any awareness of heartbeat or different heartbeats, irregular.
No, I don't.
Okay, now I
It's
examine the
regular.
face for the. Before going to the face, any leukonychia in the hand and pallor in the hand?
No,
No. The capillary refill? Any signs of sepsis?
normal. Yeah.
Normal. The eye for pallor and jaundice?
No, he's not pale. He's not jaundiced.
Not pale, not jaundice. Okay. The skin and the stentigger and the mucous membrane, is it wet enough? Or signs of dehydration?
It could be dehydrated. Yeah.
Yeah. Okay. I will offer tilt table test, and
Mhm.
I will examine the heart now, the apex beat in the place.
Okay, apex is in place. Yes.
Any heart murmur, especially aortic.
Mm,
Any aortic stenosis murmur.
No murmurs.
Any regurg.
No murmurs. No.
Any okay, hepatojugular reflux. I will check for raised GVP.
Normal. Normal.
Normal. Any fine basal crackles.
No, normal.
Okay, the site of the portacath, is it infected? Any redness?
No, it's normal.
And the temperature was normal, right?
Yes.
Okay, the abdomen quickly for any signs of chronic liver disease.
No, there is no signs of chronic liver disease.
Okay, the leg for any rash.
No rash.
Any joint problem, Mr. Ahmed?
No,
And no skin rash at all.
no.
Okay, now I will examine the leg for edema. Any leg edema bilaterally?
No edema.
May I know what's your concern, Mr. Ahmed?
Yes. Will this be cured?
I appreciate your concern, Mr. Ahmed. So far, we have possible causes, and we have to confirm what the reason behind this feeling. One of them might be related to the medication you are taking, which can lower your blood pressure, along with some low volume of fluid inside your body, makes you more. I mean, you might have this attack whenever you stand up from sitting position. It's called posture hypotension. We have to admit you right now to run blood workup and to confirm the possible cause for that. You have any other concern?
No, thank you.
Okay.
Okay.
So we will admit you and we will confirm the diagnosis by doing some blood test and some scans to your body.
Yes. Okay.
Yes, time is up. Let's go.
So yeah. So can you give me a summary of the case and differential diagnosis?
Yes, I missed the lymph node. Does he have a lymph node? Okay.
No, he doesn't.
He doesn't. Okay, Mr. Ahmed, 80 years, patient, known case of cancer colon. Since 1 year, he's taking chemotherapy every month, 12 session now. And after the session of chemotherapy today, he had dizziness and blackout. According to his note and history, it was started recently and for the first time ever. It was gradually. Now he lost the awareness and the consciousness. He denies any shakiness, any hypoglycemia, any uh, post-ictal state. And yeah, he had only some abdominal pain during the attack. There is a history of
No,
surgical.
no pain, no pain.
You told me there is tummy pain. Okay, no problem. Okay, he has history of, or he had history of surgery, lobectomy in the liver as metastasis from the cancer. He's known hypertension on amlodipine, lisinopril, atorvastatin. The chemotherapy medication, he couldn't give me a full name, but I guess one of them fluorouracil. He
Yeah.
has also catheter, which inserted 1 year back, portacath, for the chemotherapy. It might be also the reason of his sepsis. However, no signs of sepsis. I mean, capillary refill and the yes.
What would
So
be your differential diagnosis?
yeah, on top of my differential, maybe it's posture hypotension due to the medication he's taking, antihypertensive medication, along with dehydration. Uh, Anemia, one of the differential. However, he's not pale and no signs of anemia. I put also sepsis related to the catheter. However, no redness or infection infection signs at the site of the catheter. The last one, paraneoplastic syndrome, as a cause of hypotension.
So a very common cause you missed. What else?
Very common other than this.
So
Yeah,
yeah, it's
the
common
common
cause
on
of the
those,
orthostatic.
posture hypotension. He has posture hypotension. So anemia and drug induced along with dehydration might be the
What
posture.
could be other reasons?
He deny any diarrhea to say this is hypovolemia. It might be chemotherapy side effect, autonomic neuropathy.
Yes. Okay.
Yeah.
So if the patient, so he has been given good fluid and blood pressure medication stopped, and still this persists. What is your plan?
Yes, I should run all investigation, including the basic workup, blood CBC for blood count, for anemia, all ferritin and all vitamin screening, inflammatory markers along with the kidney function, liver function, and also we can do urine dip and hemoglobin screening. Diabetic screening.
Yeah.
Sepsis markers and cardiac screening for ECG and Holter and echo
Yes.
to rule out also cardiac causes in such age. However, no murmur in this patient. Yes, screening for ferritin and full electrolyte is very important as well. Might be hyponatremia related to also the medication he's receiving.
Yeah.
Other than this, you could do screening for chest X-ray, CT, CAP to look for other malignancy and secondaries in the body.
Yeah. Do you know any specific investigations in his case?
In his case, yeah, we can do a nerve conduction study to confirm
Good.
and the drug level for the chemotherapy. I mean,
Okay.
for neuropathic pain or autonomic neuropathy, we can do some confirmatory tests to the nerve conduction study. I mean, and
Okay.
in the gut.
What is the plan of management? How we will manage the case?
Yeah, this patient need to be admitted as he has frequent attacks now, and also to be investigated. And according to the cause, we will manage this patient. ABCD approach, if the patient is shocked, to start him as medication antibiotics after sending full septic screening if we suspected sepsis related to the catheter. The catheter inserted for a long time now, almost 1 year. Along with immunosuppressant, he might be also, having infection, bacteremia, or any other ongoing infection like UTI, or especially if the patient is the dementic one. Multidisciplinary team approach, including the gastroenterologist, general surgery, like infectious disease, clinical pharmacist, social and physiotherapist, and dietitian, and also nephrologist in case he has any kidney affection.
What
Treat
medication?
treat according to the if sepsis, we will start broad spectrum antibiotics. For the bacteremia, I mean, start by tazocin. For the gram positive and gram negative, plus Pseudomonas. We can consider antifungal if the patient has risk for fungal infection. Still, our patient is immunodepressed or immunosuppressed. This is for the sepsis. For the posture hypotension, should assure good volume and good hydration. We might need to insert center line or to do some invasive monitoring of his hemodynamics, either by ultrasound or by center line, central venous catheter, to assure good hydration.
Do you know any specific medications that may improve?
Yes. Yeah, we might need elastic stocking to the legs. Fludrocortisone might help also if the patient is having autonomic neuropathy.
Okay. Okay. Good. So
Yes.
yeah, so this is yeah, so good. Can I comment? Yeah.
Sure,
So
yes.
so it's a so so it's a case this gentleman has a post chemotherapy he's likely autonomic neuropathy. The significant postural drop. So it may be metastatic lesion, as you said. So first things common, which is dehydration, blood pressure medication, autonomic neuropathy, Addison disease possibilities, and unlikely to be related to that. We don't know, but the cancer should be ruled out as a metastatic lesion relating to his orthostatic hypotension, as you said. Okay, so investigation-wise, it should be included also the cortisol level in the morning and plus or minus
Yes.
synactine test, short synactine test.
Yes, you're right.
And continuous blood pressure. So you said all of these good. Also, so in the in the tests also, we will need to, in addition to the CT scans, we will need to maybe plus or minus MRI scans. In the brain also. So discussing about the management, it's a multidisciplinary. So first, multidisciplinary team approach with the education. We need to. There is also medication of. It's good you said fludrocortisone. Midodrine can act also in the in postural hypotension. There are many workup that's possible according to the reason and cause. So the neurological assessment here is important because autonomic neuropathy could be part of sensory or motor neuropathy or generalized neuropathy. So we may need to do also tests for. So you mentioned possibilities of the. So first, starting with the common, you said tilt table test. I'm not. Tilt table test. You said
tilt table test for the vasovagal. Yes.
The vasovagal. Okay. He had. So he had a pre-syncopal episode along these significant postural drop in blood pressure, and also there is unrelated. He mentioned to you blank episodes, which could be absence seizures, that could indicate it's just unrelated thing that just to see. Similar when the patient says, "Okay, I present with palpitations and I have something else unrelated," in the presenting complaint. So to remember it again and say, "Okay, I will do for that palpitation, ECG, and Holter."
So you mean don't pay attention to that. Yeah, just distracting. Yes.
Yeah. So the blank episode he may need for it.
Yeah.
EEG, MRI, brain, and to look for any metastatic lesion.
Yes, you're right.
Okay. So I'm not sure if so more common is the posture again. So the management. So before the management, we were yes, we were in the management multidisciplinary team approach and improve on the. Let me tell you just a second.
I think we have to stop the medication first. I should mention
we
this.
will have to stop the medication.
Yeah,
You said
we have.
it, I think. Yeah. We need to think of also. You thought about Parkinson very good and Parkinson plus, and also I think we need if well. I don't think his the patient mental status is okay. So no need to say the mental status examination, right? Because to check if there is a problem in dementia possibilities and MoCA test related maybe to Parkinson's, but that's far away, right? Lumbar puncture again is not needed if there is nothing in the examination. Okay. To exclude the Guillain-Barré syndrome and other causes of autonomic failure. There is also other connective tissue disorders, Sjogren syndrome. You covered, I think, all that in the assessment that can be related. Can be also Lambert-Eaton and can be related, but not very common.
Yeah,
It's rare.
no neurological symptoms or weakness.
No neurological exam. Yeah. In the treatment, you need to you have screened the you have you have screened the need of actually any sphincter disturbance, so whether to need to treat it or not. How is his GIT function, and yeah, okay. How
Can you
is
repeat the differential yes again for
yeah?
for
So differential
adults? Yes.
diagnosis is so first postural hypotension, secondary to medications, dehydration. Second is autonomic neuropathy. Third
Okay.
is hypoadrenaline.
Yeah, Addison.
Addison, yeah.
Okay. And we can say here Addison due to infection or metastasis.
Infection.
Yeah, I mean
Uh,
bacteremia. I mean, like in the case of meningococcal.
هي بكتيريا ذات نفسها تعمل كده.
Yeah,
هي
it
البكتيريا
can
نفسها
suppress.
بتعمل
Yes,
كده.
exactly. Yes, exactly.
تعمل كده اصلا، دي اول حاجه المفروض تيجي في دماغي، ان الراجل ده عنده انفكشن ولا لا.
Yes, exactly. Yes. So with any
طيب وحضرتك قلت
infection.
ميديكيشن
Mm,
بوست هايبوتنشن ديو تو ميديكيشن ديهايدريشن.
yes,
ايه تاني؟
yes. What else?
ميديكيشن what else؟
Postural hypertension
yeah.
and medication.
Autonomic neuropathy.
Autonomic neuropathy. I think we can put autonomic neuropathy due to chemotherapy, because some of chemotherapy are neurotox or toxin to the
Yeah.
has toxicity on the nerves. Yes, like
But
vinblastine and yes.
did you ask about vomiting as a side effect for chemotherapy? Maybe
I
this is the
asked
trigger for dehydration.
Yeah, I asked for any loose motion or throwing up, but I specified to of blood, throwing up of blood. But I
Okay.
asked at throwing up.
Okay, and in the history, the doctor who prepared the case, is there vomiting, history of vomiting?
No
Dr.
vomiting.
Abdullah,
Like throwing up?
There was no vomiting.
No vomiting.
No, it wasn't there.
No,
You mean as
okay.
a side effect of the
A side effect,
chemotherapy?
so it is the cause of dehydration along with the medications.
Honestly, he said, I am not taking good volume and good water. I asked him
Yes.
frankly this question. He said, no, I am not taking good volume and
Yes.
water, good water. I'm out.
Not
So
taking, yes.
once he mentioned, yes, you can put it as differential due to dehydration.
Okay, and you mentioned for the investigations, nerve conduction studies. So why are we doing them?
As a
So,
part of neuropathy. Yes.
You
Generalized
can, yeah,
neuropathy.
if you
autonomic
suspect autonomic
neuropathy is
you should screen for other nerves. The easy accessible one is the EMG, nerve conduction studies. Also, the other myeloma screening.
Electrophoresis and protein. Yes.
Yeah.
Myeloma for what?
why myeloma?
Why myeloma?
Paraproteinemia.
It can lead
Why
to
myeloma؟ هو الراجل عنده
neuropathy.
cancer.
Yes, it leads to neuropathy.
No anemia. Yes, they mean no manifestation of multiple myeloma. But he's talking about the topic itself, the autonomic neuropathy. Okay.
Yeah, yeah.
For doctor who asked about how to screen for autonomic neuropathy specifically, I think if autonomic neuropathy it's not concerned to an organ, so it can be for the blood pressure. So how to examine by sitting and standing, which hypotension. For the gastric emptying, you can do the gastric emptying and the motility study. So no specific investigation for the autonomic neuropathy to be done. You can do according to the organ involved. Even autonomic neuropathy can do impotence, right?
Yes.
So it's it's a general term. You can't specify what is the autonomic neuropathy, but one of them is the blood pressure fluctuation, sitting and standing. but no specific test for autonomic neuropathy unless
So
you have. Yes.
what is the cause for dehydration now? If he's only not taking enough water, but what else
But
is the cause?
the
if it is-
medication
Very
as well.
simple. Yes.
Which medication exactly? Like the chemotherapy or the antihypertensive drugs or
The
what? Because this is his,
antihypertensive.
there's no change in dose. He has been taking the same therapy and
Yeah,
like
but
what is the
No,
cause exactly?
it can happen after. It's not necessarily to happen from the first session, or yeah. So
So
it
is
could be combined effects. We are not sure. Like
so
nothing 100%
chemotherapy,
in practice.
yes, I understand, but is it a known side effect of chemotherapy, dehydration?
I'm not sure about this point. No, I'm not sure about this point.
don't forget, Dr. Ishi, he's taking captopril, right? Or
He takes
lisinopril, sorry,
yes.
lisinopril.
Mm.
And the ACE itself has some diuretic effect,
Yes,
right?
exactly. You are right there. Yes.
Along with some dehydration, it will be more aggravated.
I
Such
have one opinion
yes.
in
Cause
this point. There is hypertension, صح? There is hypertension.
For what? For the medication? No. As a
Side
diuresis, not
effect of
not as a first
antihypertensive.
dose, not as a first dose, as a dehydration
No,
exaggerated
which
by.
of the side? I mean, one of the side effects for if inhibitors there is dose hypertension.
This one when first attack, as you said, or first ingestion. So you can suspect it whenever he took it for the first time, or he increased the dose recently like that, or he added a new medication to this medication.
Yes, Dr.
but in
Bassem,
this
actually,
case,
there is very
nothing
important
of this
point
has
you missed.
happened.
Yeah. Okay. Dr. Abdullah will say something. Yes, Dr. Abdullah, what?
The driving is very important.
Yeah, I was about to ask. However, he is 80. Why he will drive while he's 80 years? Someone can drive him. No,
But
you're
maybe
right.
he
I
doesn't.
wrote it. I wrote it in the paper. But
Okay.
when I was about to ask, I shift to the examination. But you're right. Since you have dizziness for unknown reason, you have to screen for driving. But be sure that the vasovagal attack is not one of the contraindication for driving. I'm repeating this information.
It's not, or is it?
No, it's not vasovagal. If confirmed vasovagal, it's not an indication to stop driving. But if still you are suspecting other than vasovagal, any reason apart from vasovagal, and you don't have confirmatory test for vasovagal and you didn't diagnose the patient as vasovagal, you have to stop him driving. I hope it's clear because we had experience. One doctor in the exam, the case was vasovagal, and she said no, the patient should stop driving, and the minus here. So vasovagal, if confirmed clinically by the history and examination, I mean nothing in the history apart from the attacks, which we are all of us know them. How it comes when whenever he stand up, or he is in the standing for a long time in hot weather. These characteristic for vasovagal, and whenever no other pathology, patient can drive because it will not affect his driving. It will not come while he's driving. Only it comes while he's standing. He's standing in hot weather or sudden stand or stressful condition. Sometimes also with cough. It comes with stress or with cough like that. I think apart from this, you have to stop driving. If confirmed, no need to stop him driving. Okay.
Yes.
Yes. Any other point to be
And also
discussed?
you should
Yes.
add rehabilitation
Yes.
plans
Sure.
for him.
Yeah.
Very important in helping the patient. Rehabilitation.
So now the management is multidisciplinary team. We will stop the medications And
So after
what's
Yes.
exclusion of
the
other
specific?
causes, secondary, if it is just multidisciplinary tumors and then with medication help, such as I'm not sure actually here in the management, is it more of if there is if there is Addison, then fludrocortisone may help, but
Yes, true.
initially if it is just portal hypertension, autonomic neuropathy, then midodrine
Yeah, midodrine,
may
yes.
help.
Vasoconstrictor, yes.
First of all, I should exclude any infection by doing septic workup.
Yeah,
I
yeah,
agree
yeah,
for
yeah,
this,
that's the first
yes.
step.
Sepsis,
Yes, yes.
sepsis is one of the possibility, yes. Patient might be in
It's the
sepsis
best
due
step,
to
yeah.
catheter, yes. Because
Due
this
to
port
due to chemotherapy.
plus, yes. By the way, infection, you should have signs of infection plus source of infection. Signs of infection, hypotension, fever, and lumps or lymphadenopathy or leukocytosis or whatever. Source of infection, the organ. What you suspect in this patient? Either indwelling Foley's catheter for a long time. This is a source of infection. Portacath is also source of infection. HD catheter, source of infection. Any foreign body will be source of infection. Before thinking about other system and chest infection, for example, you have to think about the foreign bodies. Foreign bodies must important to you must rule out the infection from this foreign body before thinking about other. However, you will send full septic screening, blood, urine, and sputum. But you should suspect the foreign body before suspecting other. I mean, the sources with no foreign body. Okay.
Nice, nice, yes.
Yes. Any other comment or point to be discussed? Thank you, Dr. Abdullah, for the case, and thank you for the practice today. Yes.
Thank you so much.
Can give us 3 differential for this case? Yeah, my net is disturbed. Okay, let's repeat it again. Posture hypotension due to medication, autonomic neuropathy for any reason, and Addison also due to bacteremia or sepsis. Driving should be stopped. Yes, I agree now. Please, the list of differential again. Yes, I think it's clear now. Very nice discussion. Yes, very nice discussion really today. Thank you, Dr. Abdullah. Thank you, Dr. Hunaida, Dr. Hadil, Dr. Shaima. I hope I didn't miss any. Doctor, yes. Thank you all, Dr. Abdullah, Dr. Mahmoud. Nice discussion, all the cases. Yes. Any question before leaving? Any comment? Okay, thank you all. See you tomorrow, inshallah, with Communication Day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.